So, good morning. I will share with you my experience with the Pentacam and Keratograph family and how we use it for cataract and refractive surgical patients. So almost 20 years ago, Pentacam was launched actually here at the AAO at that time. This was the very first version of the machine. Then we have the Pentacam high resolution coming in 2007, launched at the ASCRS at that time. Then the AXL was launched at the ESCRS in 2015, and the AXL Wave in 2019, 2 years ago, at the ESCRS meeting. So there's a very long tradition now, and it's like a fourth generation of machine, at least hardware, software, much more versions of it. And what we do nowadays is when we use the Pentacam AXL Wave, we can apply it in everyday situation in the clinic screen. Every patient that comes to us for comorbidities, referring to the cataract refractive patient, for example, for early ectasia, refractive display, for refractive corneal surgery, the staging, Berlin ABCD, for pre and post cross-linking in the keratoconus patient. But if we also look into the anatomy for like a phakic IOL, we can look at the anterior chamber anatomy. We can do IOL calculation with all kinds of formulas, and we can measure everything, axial length as well as the corneal data we need. There are all kinds of IOL formulas implemented in the system, and you have an integrated database where you can also fine-tune your data. And then there are some interesting tools also which we can use for the patients to explain them if there are some issues with their vision quality, and we can kind of quantify that. So the new thing from the Wave, so to say, are things like an objective refraction, visual performance analysis, as I just said. And then we can actually look at pre or post-op problems of the patient and can offer with one measurement a lot of solutions here. And as I just said, the IOL calculations formula are really up to date now and are very, very interesting. So this is a full sequence overview, what you get here in a normal phakic eye, or not really normal, because you see already that there is some issue here with the visual quality. So you have the total visual performance. You have the iris image, the scotopic and mesopic version of it, retroillumination in there, iris photo. Then we have the refraction, as you can see here, the aberrometry, biometry, axial length, and so on, tomography. And the question is, why is the total performance here so kind of fuzzy? Yeah. So the machine can look at the corneal plane, at the lens plane, and then you can come up here, for example, you see this is the cornea, and here the vision quality is quite good, so it's not corneal aberration here. And the problem here is the lens, as you can see here. The total performance, it's compensating a little bit of it, but the total performance is therefore some fuzzy. And the reason here is, if you look at this very clearly, a kind of presbyopia and early cataract, which causes this problem here, and you can define that. So for everyday practice, we use this display here. We have the wavefront, the internal, the total. We can subtract them from each other. We have the retroillumination photo, where we can also use this for documentation, especially if we have still pretty decent visual acuity, but a clear subcapsular cataract, for example. You can prove it if some insurance company is actually asking for it. It's very nice. And another thing which I like, and I will show you some cases, is also that you can very nicely measure the axial alignment of a toric lens. Due to the retroillumination photo, you can very nicely show that, and you can also do an overlay with the tomography, and then you see if your toric lens is really fixing the problem or not. So let's look at some cases. Here we have a patient who got surgery somewhere else, and he got a trifocal toric lens implanted. You can see it's a higher myopic patient, and the target axis was 100 degrees for the right and 91 for the left eye, and you already see here that there's something wrong. But let's first look in all the data. We can see that the patient has a residual astigmatism, even though he got a toric lens. Uncorrected visual acuity is somewhere between 20/30, 20/25. but potential visual acuity would be 20/15 or something like this. So you see here the Pentacam in the first view. Of course, you have the corneal astigmatism. You just correct it from the inside, not from the outside. And for both eyes, as you see here. And it's a very nice regular astigmatism. It's nothing funny around this. So let's look here at the other features of the patient. Go back. And again, nothing really special. And even the total performance doesn't look so bad. It doesn't look like 20/15 vision, yeah, but it reflects a little bit this 20/30, 20/25 output. So when we look at the lens, we see here the cornea, of course, is kind of fuzzy. The lens should be fuzzy also a little bit because it also has a toric component. And then the resulting image is okay, but it's not perfect. So cornea, it's okay. Internal, it's difficult to decide. Total wavefront gives you that there's some incomplete correction, as we can say. And the solution is when you look here at the lens, we have a decentration of 10 degrees. We can then look, for example, with the Berdal-Harden program, how much do we have to move the lens to get a better outcome, which is important. But now we also have some features in the Pentacam. In the newest version, there are also some things where you can look at this kind of stuff, use the Barrett formula, and then you can decide if you have a situation like this, if you want to exchange the lens, to piggyback, or if you want to rotate the toric IOL. This is also implemented. You don't need to go to that web page, which we used to do for a while. Yeah, you just need here all these data, which are, of course, automatically inside the program. Yeah, this is just an example. This is not the same patient. Here we have a alcontoric patient, which is offline. And then you can go through all the values, and then you can decide, for example, if you want to rotate it, it tells you where you have to rotate it to. If you want to do a piggyback lens, you can't really do that in the US, but in Europe we can apply a toric add-on lens. It will tell you which one you have to use. Or if you want to exchange the lens, it will calculate the new toric lens you have to put in. So this is really very comprehensive, a solution for all problems. Another thing I would like to talk about is the Keratograph, and especially the dry eye screening function, which is essential for me in cataract and refractive surgery, and which gives me also a lot of good ideas when I look at my patients. We have a couple of systems here. We have the tear film scan, we have the Meibomian gland scan, we have the imaging of the break-up time and the fluorescence on the anterior surface, and we also have some more detailed tear film analysis here, and we want to go through that. So when the machine is doing that, it actually is switching the magnifications, because if you look at the camera, if you want to see the redness, you need a different magnification as if you just want to look at the anterior cornea, or if you want to go into looking at the tear film and the osmolarity, or how much lipid is there, the fatty part of it, you also need different type of magnification. This is all automatically implemented in the machine, integrated. So we can measure the tear production, the meniscus. We can do a non-invasive breakup time. We can check the lipid layer and the dynamics of the tear film. We can do a meibography of upper and lower lid. We can also look at the red scan, as how the bulbar redness is. And we can also look at corneal and conjunctival staining. So what is the process? The process actually is very much aligned to what are the official pathways to differentiate between evaporative or aqueous deficiency dry eye symptoms. The machine fits more or less in all of these different step points in order to give you the information. And then you get actually very interesting information. For example, this 9 images, pictures here, where all the measurements are visualized, but you also get that in terms of tables and a kind of report that is giving to you. So the tear film, the lid margin area, the lid function, also the blink frequency, conjunctiva, cornea, redness, and so on. and also a questionnaire is there, and it's from green to red, giving you an indication how bad or how good the tear film is. So if you look at the MIBO scan here, you have your image, and then you have also comparative images that tell you the grade from 0 to 3, and it will tell you where your patient fits to. So it's very automatically and very intuitively. The non-invasive keratograph breakup time gives you a kind of very detailed image where the tear film is good or bad and where it starts breaking up. You can really quantify that almost, and you can also use that for follow-up studies very nicely. So it's a very, very interesting tool. Then we have, as I said, this 9-picture story, and we get an output. We can actually give the patient a kind of paper with a dry eye report. In this thing, you can see all these 5 points, what is green, red, or borderline. And here you see for everything also a marking. Is it in the green area? Everything is fine. Is it red? That's the problem you have. And there's also explanation so the patient can understand what we did and what we examined. So you get a very comprehensive dry eye readout here. Let's look at some patients and how we may change our decisions on how to deal with the patient. Here is a patient who got a cataract with a femto laser and also a trifocal lens. First week after surgery, everything is great. Visual acuity 20/20, something like this on the left eye. Then 4 weeks later, vision drops down to 0.4. So there can be a lot of things now going on. Now, one patient, of course, is not happy. So first view on the Pentacam doesn't really show you anything special on topography or wavefront or something like this. So this is all good. But then let's look at the tear film. You see already a difference here in terms of the volume of the meniscus here. It's a green on the right and it's borderline on the left. Then you have the same type of tear film. There's a little bit deficiency of lipids here. Not really bad, but also borderline, but it's in both eyes, which makes also sense actually. But then you see a huge difference in the breakup time, which is quite a bit. It is also shown on the report here. So you wouldn't just treat now, you would treat the patient just for the dry eye and then you will be fine with the visual outcome. You don't need to look for cystic macular edema or whatever, all kinds of stuff. It's very easy to differentiate. Let's say another patient here is a toric eye patient. Also first day after surgery, very nice outcome, everything is good. But then after 2 weeks, uncorrected acuity is only 0.5. So of course astigmatism didn't change so far. Could be an option, like you have surgically induced astigmatism and then your toric lens doesn't work, but this is fine. If you look here at these images, it's okay. We're still talking the same thing, that we have, of course, a cornea which has some issues because of the astigmatism, a toric lens, which also is not 100% crisp, but the resulting image kind of corresponds to the 0.5 visual acuity. And here we do the dry eye report, and what we see is more or less that almost everything is okay, actually. Most of it's in the green range. There's not much differences here. And the problem in this case was IOL rotation by 10 degrees. So this is the indication not to wait until everything is better. This is the indication now to do directly IOL rotation. So in the one case, we were just staying cool, giving some eye drops, and here we have to go into action. And so this report then helped us actually to exclude the one and the other pathology. So with the AXL wave, we get so many data. It's just really one machine we need for everything. We don't need 5 different machines, which we used to have for, especially for refractive surgery. Everything is in there. And we can also look at post-operative problems or a referral patient that has some issues. And together with the keratograph and all the data we see for this comprehensive dry eye report, we really have all the tools that we need, to have the solution for 99.9% of all of our patients. And I think that's a really a win-win situation, so to say, for you if you have this machinery. So thank you very much.